Welcome everyone to the inaugural VA Industry Symposium on Digital Health. My name is Jennifer Goldsack. I'm the CEO here at the Digital Medicine Society, or DIME. For folks who may not know DIME, we are a nonprofit dedicated to advancing the safe, effective, ethical, and equitable use of digital technologies to optimize health. We are delighted to be partnering with our VA colleagues on today's discussion. I think one of the things that are really important as we consider the conversation ahead, as we consider this day ahead, is that this isn't about technology. While we might be here to discuss digital health, we are here to solve some of the most pressing challenges in healthcare. We are coming together to think about how this new suite of tools in the toolbox, from sort of sensor technologies through to new sort of decision-making algorithms to a variety of communications technologies, can be harnessed to really reimagine what we even mean by healthcare. There is the possibility for us to think about defining healthcare or good healthcare as how well we keep people. How good are we at keeping people, and in this case, and for the purposes of our conversation today, veterans out of the clinic. This is the possibility that we have on deck today. And at DIME, we are very proud to share this vision with our colleagues at VA. Before we dive in and before I hand over to my colleague and the Chief of the Office for Healthcare Innovation and Learning at VA, I do want to thank participants in today's session. We have a world-class lineup of innovators who are joining us here today to really think about putting digital health into practice at VA for veterans. I also want to thank all of you on the line joining us today. Today is not just going to be about fantastic, thoughtful, action-oriented conversations, but as Ryan will describe, there's an opportunity for our conversations today to really shape VA's commitment to innovation, commitment to world-class care for veterans, commitment to their public health mission. And really, we want to learn from you. So let's talk very briefly about the agenda we have on deck for you today. And my colleague, Smit Patel, Director of Digital Medicine here at DIME, is going to pop the agenda for all of you into the chat. As we think about bringing all of you together, I would ask you to join us in the conversation. We're going to be working through 3 different therapeutic areas to start with, thinking about the power of digital to improve diabetes care, cardiac care, and mental health. We'll then talk about the infrastructure considerations we need to bring this to fruition at scale and not just have an endless litany of point solutions. And then finally, we'll have a conversation about the VA as home for digital innovation. And we want your input. There's 2 ways for you to do that. So let's just do some housekeeping before I hand over to Dr. Ryan Vega. We encourage all of you to participate in the conversation live and throughout the day using the chat function. We have several thousand attendees who will be joining us throughout the course of the day. Please feel free to sort of drop your thoughts, any pertinent links into the chat, and really sort of discuss with one another the topics we have on deck. Following that, we invite you to capitalize on the opportunity to ask your questions directly and live to our experts joining us today on the panels. To do that, you can use the Q&A function. If you drop your questions into the Q&A, we will be curating those questions for the moderators. And if we have the opportunity, we will bring you live onto stage to pose those questions directly. So with that, I just want to thank all of you on the line today for joining us. I want to thank again the phenomenal experts who have joined us on the agenda. And Ryan, let me hand over to you so you can welcome everyone and share your vision for putting digital health innovation into practice for veterans at VA.
Well, thanks, Jen. And just to echo some of her comments, really appreciate everyone for being here today. I think not only is it an incredibly exciting lineup, but certainly a topic that has gained a tremendous amount of interest within VA and broader in what it means for how we can reimagine care, not just for veterans, but for all across America and even in some ways the world. And one of the things I want to start by focusing on is talking about our mission. And when I say our mission, I mean collectively the mission of the VA, but it is all of our mission. Whether you are a veteran yourself, a taxpayer, a caregiver, a spouse, or a loved one of a veteran, in a lot of ways, the VA mission is our mission. It's a promise that we make to the men and women who serve us that we will care for them thereafter. And one of the things that's really important in this notion of to care for is that the mission of the VA is not to provide healthcare alone, but to care for these individuals, which means it's not good enough to just treat the diabetic, but it must be about how we enable that individual to live a more full life, or in the best case, to prevent diabetes from ever occurring, which means we must fundamentally think about healthcare not as the receiving point of the patient at a time when they're ill or a time when they need us, but much further upstream in the ability of how we envision healthcare delivered more outside the walls of the traditional hospital and in the communities and in the homes. And what we see at the inflection point, somewhat accelerated by the pandemic, or maybe perhaps significantly so, is that the technology is starting to get to a point, as is the policy and the regulation, that can enable us to truly imagine a new world, a new system in which patients are in much more control of their care, a system in which there is far more access, and one in which we can start to see conversations that will lead to action around more equitable care, care that doesn't just remain fragmented or disenfranchised, but benefits us all. And what today is about is not just a conversation, but it is about how and why VA should play a fundamental role, not just because of our mission. While we do recognize, and maybe I'm biased, that I believe veterans deserve the highest quality, the best care, we also have other missions. We have a mission to educate and train the future generation of American workforce in clinical care. We have a research and development mission. And during the pandemic, a mission that we proudly took upon ourselves is to be the backstop of the American health system in times of crisis. And combined with some of the work that is happening, an infrastructure that burgeoned out of the pandemic to assist our sister federal agencies in medical device testing for solutions that were being printed by additive manufacturing in supply chain crises, is a recognition that we have a fundamental role to play in not only advancing healthcare innovation, but in helping to test and to vet and to demonstrate clinical efficacy and safety of devices for the betterment of not just veterans, but for all healthcare. And I think that's the spirit. That's the important role that government can play and should play. And particularly as we sit here to prove out the efficacy, to prove out alternative payment models, to push policy and regulation forward, evidence will be required. And the role that the government, particularly in this case, the VA, can play in moving that narrative forward and proving out what the art of the possible can be and should be, I think is incredibly compelling. But it won't happen alone. I'd be remiss if I didn't acknowledge the incredible relationship and the partnership and the work we are doing with DIME. It takes organizations like that to help the VA to continuously advance forward. And all of you, everyone on the call, whether you're an employee of the VA or not, it will take all of us, a collective effort, a shared ideas, arguing at some point about the best way to get to where we want to go, and equally a recognition that we must be obsessed with this idea that the solutions that will come have to be meaningful, not just meaningful for the patient and not just meaningful for the clinicians, but meaningful in the sense that they will enhance that experience for our patients, in our case, our veterans, their caregivers, our providers. These are solutions that will be adopted, solutions that we can scale, and there's no shortage of them, which means at times we must be critical. We must be willing to really dive deep and understand, how is this going to make a difference? And to ask the questions of, how does this allow care to be more effective and equitable? How does this increase accessibility and efficiency in the care that we provide? And if we do that, and if we move even slightly over the next year, we will get to, I think, a point in which we will see not just care for veterans, but care for all of us, getting to where we all hope it can be. And I want to take a moment now to introduce Molly Coye, our keynote. And I certainly could read Molly's bio, but I would be honest that it does not justify or do much diligence to her true expertise or brilliance. So I want to focus on 4 sort of key points. Dr. Molly Coye is currently the executive resident at AVIA, one of the leading health networks for health systems seeking to transform care and experience through the deployment of digital solutions. And previously an executive sponsor of the Medicaid Transformation Project that focused on scaling solutions to address some of the most vulnerable populations that many of us care for. She has deep experience and involvement in the provider system. She was previously, or is now, the Chief Innovation Officer for UCLA Health. Experience with health plans and advisory experiences. She served on the board of the directors of Aetna. Currently a member of the board of directors of AMMD, Ginger, Consejo Sano, and Health Tech for Medicaid. Also has this unique experience with having public health and bringing that to the work that she does, where she served as the commissioner for the state of New Jersey, the director of the California State Department of Health Services, and the head of the Division for Public Health Practice at Johns Hopkins. And she's a medical professional leader for 3 decades, serving on the board of AHA, the American Hospital Association, the American Telemedicine Association, PATH, APHA, which is the American Public Health Association, the California Endowment, and the China Medical Board. Again, incredibly privileged. I've known her through some colleagues. Her insights, her passion, I believe, will come through, but equally her ability to articulate not only what is needed, but what is possible, certainly as always gravitated me to wanting to push harder and further. And we're so very fortunate to be able to hear from her this morning to kick us off. Molly?
There, sorry. Okay, hi, can you hear me, Ryan?
Got you loud and clear.
Okay, great. Thank you for that over-the-top introduction. And good morning, everyone. I see from the chat box that are people all over the world and certainly all over the United States. And so I'm grateful for this opportunity to talk with you. This is an exciting day ahead of you, ahead of me. I'm going to be listening in. And I really just want to start out. I'm going to switch to my screen here and let me do one more check. Ryan or Jennifer, is this coming through as the slides now?
I can't see the slides, Molly.
Okay, let me just do what I think I should have done all along. Just a second.
Bingo.
There we go. Okay, and let me minimize there. Okay, so our topic today is building a new value chain in healthcare. And my hope in the next 20 minutes or so is that I will be explaining to you adequately why I think passionately that this is a very important capability for a health system in the future, for any health system, and especially for the VHA. I'm going to start with a couple of, let's see, I've got to do slide forward. There we go. A couple of disclosures. You can read about my various memberships as Ryan went through them. But the first disclosure is that I've worked with the VHA for a fairly long time. Back in the 2000s, VHA was a member of a nonprofit digital technology and health organization that I had. And I worked very closely with the staff then. Today, the Veterans Health Administration has worked also closely with AVIA, and Ryan Vega has been very important in the leadership of that work and made us really appreciate the colleagues and the network across all of the VHA that have been working for the last 2 to 3 decades, at least in my experience working with them on transforming care. And chief among those is my personal heroine, Carolyn Clancy. And many of you in the VHA have worked personally with her for a long time, which is a real privilege. And I'm very proud to have been able to work with her over the years as well. So I congratulate you all on, excuse me, retaining the leadership that has the most experience and is really going to be able to supplement and lead a lot of the work. So with that background, I also want to make one specific disclosure here, which is that this presentation is going to use examples of early stage digital devices because they represent some of the most disruptive changes ahead. Some are from the VHA, most are from the private market, but I'm using their inclusion here or them as examples to be illustrative, not because of individual endorsement of that particular solution. It's important that we understand the trajectories of these innovations and their early impact in order to imagine what broader scaling of these kinds of innovations can mean. So let's dive in. Today, I'm focusing on what the VHA is working on very hard, which is the framework for the future of digital services in the VHA, centering around the question of how digital technologies and services can accelerate, even radically accelerate, the path to the fundamental transformation of healthcare for veterans, and suggesting that it is very helpful to develop a vision as you begin a process or as you're partway into a process like this for what this transformed health system will look like. Visions like this can help to orient you and prioritize your work. And I'm giving the example here of Kaiser Permanente, which back in 2001 convened a group of internal and external leaders to envision what their goals for care for their population, then I assume it was around 5 or 6 million. Today it's more than 10 million of patients, but still not close to the VHA, to envision what care would look like in the year 2020. And they have, through their innovation, exceeded much of what was in that vision, but more importantly, they stayed true to that vision through several changes in leadership and through a tremendous barrage of innovations that they could have adopted. It gave them a lodestone to relate to as they worked their way through all of these possibilities. So what might that look like? If you look at the components of healthcare that virtual first, digitally enabled services and technologies are transforming today, you can tick through them: prevention, triage, diagnosis and treatment in primary care and community specialty care, referrals, chronic care management, and mental health. And this is obviously a very brief list. You can make it your own and quite individual to an individual system. If we were addressing just a rehab hospital, for example, it might be a slightly different value chain. But as we look at how digitally enabled services and technologies can drive these forward, we can see a new value chain emerging. And this is what I would suggest might be a new value chain for healthcare. And I believe that the value chain should express ultimately the value to the veterans and their families. It's the VHA patient's view of healthcare, informed by and driven by the wonderful clinicians and administrators who actually are organizing and providing that care. So the changes will be driven by them in order to better provide value for the patients and their families. And we can segment these out into, again, triage, primary care, emergency department, community specialty, chronic care, mental health, and even the wraparound services to support veterans and their families as they're going through tertiary, quaternary, much more complex healthcare needs. So a value chain, what is a value chain? It describes the value that you produce for your patients and breaks it down into component stages or buckets to deepen your understanding and drive action. Transforming healthcare requires changing the processes and activities, the work that you do at your organization, so that your business outputs, your results, have a substantially greater value to your customers. In this case, we all hate the word customers, but this is originally Michael Porter in 1985, the business school language that first described this concept, for the same or lower costs. So you're producing greater value with the resources that are given to you through very complex process in the VHA, admittedly. This value chain will be driven by or enriched by a whole panoply of new tools. And that's what, Ryan and his colleagues, and many of you are on the phone, but those of you who have just simply been watching this go on, this is a really tough issue to sort through all of these tools. But I want to give a couple of examples of how big the scale for this vision can be. Some of you may know about a small company called Buoy Health that was developed at Harvard's medical informatics program. They posted a free solution on Google search that said, if you wake up in the morning and you need to figure out what you might have, how serious it is, and where you should seek care. And within the first 15 months, they had 40 million users, 23 million of them unique users, meaning some of them were coming back because they found it very helpful. And they achieved 3 million visits per month in that first 15 months, which it took 10 years for the best known Doc Finder application to meet, and 7 years for Netflix to get to that point. This is a high impact innovation that targets convenience and impacts user experience and cost at scale. There are multiple similar international offerings that have been developed in European NHS settings, and some are incorporated in virtual primary care offerings in the United States. And I'll leave you to look later at this JAMA article, which was a lot of these young companies, as you'll appreciate, and Ryan and his colleagues know well, have very little in the early stages of published research, but this was an early piece of research published that showed that the urgency of patients' level of care, once they got appropriate information, decreased in more than a quarter of the cases and increased in about 1 out of 20 cases. So roughly a third of patients coming in really didn't need more than watchful waiting and patient education and support. So that gives you some idea of how much of triage could be offered and scaled without requiring people to come in deeper contact with the healthcare system. Another example, and this is the only one that I have a personal relationship to, I'm on the board of Ginger, and I'm excited about it because it's an example of what we call a full stack platform. It's basically a service, which is very much what the VHA has done and can do in many areas. So it's from the very point of entry all the way through the care for a digital or virtual patient through streaming therapy up to the point where they need to come in for personal care, in-person care. And that integration of multiple levels of services is very important for patients because it makes it feasible. You're not jumping from app to app to app. And so ultimately, I think one of the things that the VHA can envision is the idea of having their own platform incorporate innovations developed at the VHA and externally. And in this case, the principal innovation is coaching, which takes what we know about community health workers and coaches in 30 years of research and digitizes it. Here's an example of a new tool that many of you may be very familiar with, which is the remote temperature monitoring for diabetic foot ulcers. This has already been scaled to more than 90 VA medical centers, and you can see the outcomes here. This is the kind of thing that makes me as a clinician look at this and say, oh my gosh, I want to get my care at the VA. And part of the goal of a vision that drives any large, complex health system has to be, what is it going to make? What is it that will make the patients and their families say, thank heavens I belong, or, oh, I really want to get my care in this system? The last tool that I'm going to show just as an exhibit is applying behavioral economics for chronic care. Some of this is so counterintuitive, it's just amazing. We know from basic behavioral economics that you can change people's individual behavior, their habits about healthcare, their habits about buying Kleenex, their habits about almost anything with behavioral economics approaches. And so these people in a young company developed a very simple smartphone-based system for supporting diabetics who were not adhering to their insulin regimen. And in a daily program, they take a picture every day of their pills, and through AI, the company can read and make sure it's the right dosage and the right pills. And they have generated a tremendous improvement from roughly 30% adherence to 85 to 90% adherence. They've gone well beyond diabetics. It now works in psychotic medications, self-care among a wide range of Medicaid and other underserved populations, safety net populations. And if you think of how stretched our diabetic health educators and all of our other in-person programs are, this is a tremendous supplement and help. So there's the opportunity to develop, like the diabetic foot ulcer detection system or this, specific innovations that once we understand how they work, we can apply those approaches to multiple clinical problems as well. How do you look from a value chain point of view at innovations? How do you think through what you really want to accomplish? And I'm just suggesting some of the core principles here. I think this is something, again, that has to be taken in-house and worked on, and there will be a whole range of specific implications and questions that would come up if you look at this within the VHA. The first principle I would take is that digital health will be, in its bones, hybrid for the next at least 2 to 3 decades, if not forever. Hybrid here means that it combines digital with in-person care, that there is almost no clinical condition or service that we can think of that is not going to have some part of the population need in-person care, but we can optimize, get exactly the right patients at the right time with the right set of needs for in-person versus those where synchronous and asynchronous modalities of digital care can vastly expand what we can do with our resources. And I say asynchronous because many of you will recognize that synchronous, which is what we think of as the old version of telemedicine, where you have a live person video streaming with a patient or family member, versus asynchronous, in which case you may be using texting, AI chatbots, et cetera, as well as, and synchronous obviously includes telephone. So I think instead of fighting over, well, should this be digital or shouldn't it? The question is really, what's the optimal care that really needs to be in person? Because that's much more difficult to provide across different geographic distances and for people with disabilities and a whole range of people. And it's very expensive and you take time off from work. You know all the reasons why in-person care can be difficult to provide. And so we actually can, in many cases, optimize the care in that way. A second question is expanding access. And I would redefine this because I think for some, certainly in the private sector, expanding access simply means making, and it's not simple, but it means giving the patient or the health plan member the opportunity to go for care, knowing that care does exist and is available. That's expanding access. But the larger challenge for us in health systems is to build engagement and trust and confidence. It's not enough to just check the box and say, yeah, there are clinic hours. We need to make sure that the patients feel relief when they come in the door or when they go online to engage with the VHA, that their trust and confidence is built on engagement and experience that justifies that trust. Thirdly is to reduce cost. And one of the things I love about working in the VHA is that those savings can be reinvested in the most productive interventions. And we'll talk a little bit more about how you might measure some of that. Accelerating quality improvement, and here we need to lead with equity, because quality is not meaningful unless we carry everyone with us. And building a learning organization with consistent application of knowledge. And this is one of the greatest areas of contribution of digital health, is to collect large amounts of data and provide the analytics, including predictive analytics, that can really help guide the leadership in the allocation of resources. Enhancing professionalism. We need better support for the total health workforce. And so each innovation that we look at, we have to see, is this going to be greater stress for them? Or is this actually going to help them feel that their care, the care they're providing, is exactly what they always wanted to do? And it's great to see the excitement of lots of clinicians as they actually experience new digital modalities. And then my final suggestion here is that it be simple. Simplify engagement and services for patients and for providers. And from that's one of the reasons why platforms that integrate point solutions are so important in order to advance the user experience. So the ultimate test in this kind of evaluation approach is, for our patients, is VHA care great? Is it truly affordable? Is it efficient and convenient? For the patients, does the VHA see me and help me anticipate problems and solve them? Are the results of my care as good as the best out there or better? And I just want to stress the importance of our deepening understanding of digital inclusion and health equity. COVID revealed substantial acceptance of virtual first care among disadvantaged and underserved populations, with marked, difficult, and disturbing inequities that persist despite that acceptance due to all these factors. And I'm not going to read through all of them, but I think it's important to understand all of these and to address these deficits and to measure the innovations we undertake, not only by whether they won't worsen those inequities, but can they provide important means of addressing that. And in each of these areas, there are very exciting innovations to suggest that digital medicine has huge contributions for digital inclusion and health equity. From there, I think what we can come to is this question of new variants, or this observation of new variants of precision medicine. What we're looking at essentially is a new meaning of precision. Precision is no more than the right care at the right time for the right patient, with enormous new tools applied. For population medicine and precision clinical medicine, digital health is driving a vast expansion of our understanding of what we can do. For population medicine, we're applying the 80-20 rule, we're advancing care for the general population, and the value chain that I was describing was largely for that 80% of the population, versus complex and the zebra. So when I did medical training, you were always, well, that's the zebra. That's the unlikely or the very complex, very sophisticated kind of required sophisticated care. But don't forget that digital platforms can support an awful lot of care for people out in that other 20% who have complex chronic or acute conditions as wraparound services. So there's a huge extension of the population medicine innovations, but also digital medicine is in precision clinical medicine, along with omics research, et cetera, generating an entire new herd or many new herds of zebras. These are patients that require integrated, sophisticated clinical diagnostics and therapeutics specific to challenging constellations of causation and response. For these cases, like the VHA, the dominant clinical enterprises in the future will be digitally stitched together expert networks, internal networks that draw on external expertise when it's needed to optimize the delivery of precision clinical medicine to hundreds of thousands of patients across time and geography. Patients with very difficult, rare, or complex diseases that never would have been able to access the kind of care that is the best care will now have access to it. And for just a minute, I'm going to flip back to the original value chains here and think about if you could essentially, at both less cost and with greater precision of delivering just what people need for triage, primary care, emergency department. And let's say that we can only in the next decade realize half the capability we might. We still may be able to provide care for immensely greater populations more frequently, even daily touches that radically change their health trajectory, move them upstream into prevention and secondary prevention, and allow us to make sure that every veteran and their family sees this as the absolutely best system with the best outcomes that they could imagine. So this is the combination in the future: the population precision medicine with expert networks for clinical precision medicine. And as Ryan pointed out, this absolutely requires research at every step of the way. And eventually what you produce will be what your veterans and their families, what your patients need, when and where and how they need it. So my final advice is that as I read through the really excellent Ryan and Jennifer report from DIME working with the VHA in July to produce an initial report on your challenges, is that I agree with all three of the sort of large conclusions that you came to, but I want to raise one point. I agree very strongly that we need to move fast and act now to fix things by doing more things for most people across the country. And boy, do I agree that digital health innovation is challenging. We need a lot of course corrections, but we can't give up. And the only point I would raise as my final one is that as you build individual digital solutions, you do want to be veteran-centric and clinician-centric. But ultimately, when push comes to shove, I think you really want to make the veterans and their families the true north, the lodestone for your decision-making I am a great admirer and actually a member of the Kaiser Permanente Health Plan, and I've worked with them closely for many, many years. They did great research in their early innovation group on remote monitoring for cardiac care in the early 2000s. That research discovered tremendously effective approaches, but they lost a decade because the cardiologists shut it down, largely because they were concerned this called into question what the role for cardiology would be. It meant too many patients could be cared for by primary care. You see the opposite of that in the Mayo Clinic Care Network, which pioneered the development of e-referrals, which essentially supports primary care physicians with specialist consults that are asynchronous, just developed in those days in simple remote email system, that essentially takes out roughly, depending on the specialty, 40 to 60% of the need for in-person specialist consult visits. So keep your absolute center of the vision, the veteran and their family, and I believe you'll go the very furthest than you can. So once more, Ryan, thank you very much for the opportunity. I have been excited and admired the VHA for a long time, and I can't wait to see what you do now. Thank you very much.
Molly, what a tremendous keynote to start the discussion today. I think that the final advice here to really make sort of the veteran and their family and sort of patients and their community the North Star, that is the best and most effective way to make sure that we are harnessing the full power of these sort of new digital tools in the toolbox to bring them to fruition for the people that we're all here to serve. Molly, thank you so much for getting us started. Really appreciate you sharing your time and expertise with us today.